Welcome back, dear dreamers. I'm Lisa Hayes, your host for Dreams for Society, and with us today, and it is actually Tuesday, January the 8th, 2019. Happy New Year. With us today again is Dr. Dan Stock. He was with us last year around this time, and he is a functional physician, does functional health care. He has his business called PureHealth Functional Family Medicine. And I love how you entitle your thesis, in a sense, as Unbiased Advice, Compassionate Service, Optimal Health. I'm in, Dan, Dr. Dan. And I love
Well, I kind of think that's what patients want.
You are so right. And I know you're very successful in what you do. And I love how you also promote this concept that I'm the boss. I'm the boss and you're the servant.
That's right.
I love that. So, Dr. Dan, last year we had a tantalizing discussion on the third-party pay system. And before we get into that, we're going to also as well talk about the Medicare system and navigate through that for people as to what choices they have under that system and what may be the best choice for them. And we're also going to talk about anything hot off the press, legislatively or whatever. But before we do that, can you add for us, to the viewers, a little bit about yourself, how you got to be where you are today?
Sure. I've been in practice 30 years now. And until about 5 years ago, the first 25 years of it, took insurance, worked for a major health network here in town, which I cannot name because they don't like people to know about the contracts they have with their doctors. And they have a clause that says I can't tell you the name of that health network. And for the beginning part of this, probably the first 25 years of that relationship, it was fine. But then as the third-party payers started telling hospitals, we'll bankrupt you unless you do it this way, and we want you to make the family doctors get in line and go on with this. As the interference got greater and greater, the hospital finally came to me and said, you complain too much about third-party payment. You don't see enough patients a day to be profitable. And so we're going to release you from your contract without cause, which, as a young kind of naive doctor who, I already thought the system was going to change to fix all these problems when I complained about it. I then went to work for a couple of different employer clinics where the employer became the third party in the thing, usually administered through a fourth party. And after those both went disastrously because they came in and said, no, you're still not giving the advice we want given, and you're giving advice we don't want given. One of those employers actually had a moldy building that was hurting his employees, and he didn't want me to tell them that was going on anymore. And then it became the reality that third-party payment will never let a doctor serve his patients. It will always make him serve the third party. And that's when my wife and I took the practice full-time. It's about a year ago, actually about 9 months ago, so that we could work directly for patients and for nobody but patients.
So the difference in terms of the pocketbook for the patient, between the third party and the direct pay that you are, can you explain that?
Yeah, so right now, if you go to a doctor who takes your insurance, or if you have Medicare or Medicaid, takes those programs, you actually aren't paying that doctor. You may give him a co-payment, which is a small amount of money, not nearly enough for him to actually do the visit and stay in business. And then he submits what he did to the insurance company or the government or the employer, and the insurance company and the government and employer look at what he did through a very draconian way of how they rate your intellectual output, because they actually do rate your intellectual output. And then they decide whether or not they think they're going to pay you for the work you did. And part of this is predicated on the idea that, look, the definition of good advice isn't by the guy on the exam table or on the exam chair. The definition of good advice is by the guy who's going to make the payment. And they have piled more and more and more definitions of what they consider good health care on this, such that physicians are financially coerced into doing what the insurance company or the government or the employer wants them to do, which has just pounded more and more and more inflation into this system, because part of this is dedicated to having the doctor order a bunch of stuff that really isn't going to be very helpful to the patient, but it's financially profitable to keep the system working. So compare that to what I do, which is direct payment or direct primary care, which is the patient pays me directly, either by hourly rate or by a monthly rate or by a yearly subscription. Either way they want to do it. And that way, the only person I'm beholden to, the only person who defines good health care is the person on the exam chair and on the exam table. And my job now, instead of becoming to make the patient do what the system wants, my job becomes to inform the patient so that they can make a very informed decision about what good health care is. And now they are in control of their health care again. And all of the financial coercions that could be applied to me by insurance companies or governments or employers or drug makers or supplement makers or laboratory companies, all of that is removed because in my contract with my patients, I have a clause that says I can't make any profit on anything I give you advice about. So if I give you, like even a vaccine, if I give you advice on a vaccine, I may get it for you at a discount through my practice, but I have to sell it to you at whatever it costs me to get it, so that I have no conflicts of interest in this relationship anymore, which is just unheard of in third-party payment. There's no way to do a third-party payment system that doesn't have conflicts of interest in it. It is, by its very nature, a conflict of interest to have a third party in the payment system.
Let's elaborate a little bit on the third-party conflict of interest, because right off the bat, you're saying that the physician isn't going to get paid by the third party who has a plethora of rules and definitions of good health. So, for example, if a pediatrician doesn't vaccinate the newborn according to the protocol, they're not going to get reimbursed?
Or they'll be reimbursed at a markedly reduced rate. Governments and insurance companies and employers now are all tracking this. Okay. They know for a given, if you say, Dan is my doctor, and then we look at all the patients who have said Dan is my doctor, and we look at their vaccination rates. And if the vaccination rates aren't high enough, well, then Dan gets paid less now. And they even have worse coercions in it than that if you work for a health network. Because when you go to work for a health network, they have clauses in their contract that says, hey, look, we can fire you if we don't want to work with you anymore. And if we fire you, you're not allowed to contact any of your patients and tell them where you're going. You're not allowed to practice within sometimes as much as 50 miles of your office. And so you have no startup capital, and you have to start a practice off from scratch, finding all new patients who don't know anything about you, because all the ones who knew something about you and trusted you aren't allowed to find out where you're at. And so the doctor is financially holden to actually do what will make this happen, not only because he'll get paid less if he doesn't, but frankly, he'll be fired and put out of business if he doesn't. And then his only opportunity will be he doesn't have any startup capital, so the only thing he can do is go back to work for another health network or employer and go right back into the frying pan. So it's kind of I guess I just give the advice they tell me to give me because otherwise I can't pay my loans. In fact, if you're a young doctor just out of school, it's even worse. They have this compassionate program for doctors now. So the average doctor is coming out $250,000 in debt. And they have a program now that if you go to work for a hospital, other nonprofit organization, for 10 years, you can get your debt forgiven. But if the hospital fires you before the end of the 10 years, you get all $250,000 of debt right back on you. So now you not only don't have startup capital, you have an enormous debt that came back to you. And I don't know how to describe this as any other way than indentured servitude.
I agree. Indentured illegal. Servitude is a nice way to say it. Because it's like blackmail.
Like the jungle from Upton Sinclair in healthcare.
I'm so sad. Yeah, that's sad for me to hear how enslaved our medical community is. The ones that do wake up to the notion, hey, I don't really like what I'm doing. I don't really want to prescribe this prescription. I'd rather give them, as you have done in the past, a vitamin D. Hey, just go out and buy some vitamin D rather than me writing this script. And what happened to you when you did that?
Well, I was working for one employer company, and one of the patients of the employer company, I should say it was actually one patient out of like 600 patients that I was taking care of, went and said, hey, we think this advice about vitamin D is weird. So the third party payer employer goes to the fourth party, which is the company that manages the employment clinic, and says, hey, we got this complaint. So now the fourth party comes to me and says, well, Dan, we got this complaint. And I was like, okay, well, let me go talk to the employer and explain the science behind it. No, we don't want you to talk to the employer, because then the employer realizes he doesn't really need the fourth party. And so they said, you have to tell me and I'll explain it to the employer. Now, mind you, this fourth party person is a second grade teacher by training, and I'm sure he's a wonderful second grade teacher. But when I sit down and say something like an allosteric modifier of genetic epigenetic effects, his eyes crossed and he has no idea how to explain this to an employer. So the employer says, I don't know. I just don't want to hear any more complaints. Fourth party comes back to me and says, Dan, you need to quit telling people about functional stuff and vitamin D. Well, you know, what am I going to do? It's been shown to reduce the risk of cancer by 80%. It's like, I can't really not do that, guys. And so I told him, well, you can have either two options. You can let me explain this science to the employer so they can decide whether that one patient was a nut, because the other 599 are all happy with it, and many of them getting better because they did it. Or you can have my resignation. And the fourth party said, resignation? Yeah, that's the one we'll take.
So 1 out of 600 people complained, and it was enough to boot you out of the system. Crazy.
Well, that's important to realize the power that the third and fourth party have in this situation.
Right.
I mean, the most horrible phrase you ever hear from a human being is, I feel your pain.
Right.
No, you don't. You don't feel what I feel. All you feel is the budgetary constraints. This fourth party has come to you and said, look, if you let me set up one of these clinics and you force your patients, your employees into this clinic, I'm going to cut this enormous cost of healthcare that's bankrupting you down a great deal. That's all the employer knows is, look, I'm bleeding out the nose for this healthcare that I'm required to buy for my employees. And so all you heard was, I don't know, the fourth party came to me and couldn't really explain it. I don't want to hear any more complaints. So the employer makes the decision based upon the only thing he knows, which is not how the other 599 feel. All he knows is the one person complained. I don't understand this science gobbledygook. And so we have to make complaints quit coming in or people won't use the clinic. And then the fourth party does exactly what he's told and says, Dan, you got to shut up. And in the worst case scenario of that, I went to work for another employer, fourth party, taking care of another third party. That third party owned a building that was making a great deal of mold toxin. We're almost sure of it. Couldn't actually prove it because it couldn't get the testing done, but clinically there was no doubt in my mind. Third party came and said, we need you to quit talking about mold. They didn't want to clean up the building. It's like, well, can't really do that. You know, kind of took this oath that said, I'm not going to, I'm going to try and get people well. And they said, well, then you're going to resign. And I said, well, no, I'm not. They said, well, yeah, you are. And wrote me a letter that said, we've accepted your resignation, even though I hadn't resigned. And that was the end of that. They had actually, up until that point, actually had me doing lectures on wellness for my patients once every month. They get all the patients together, let me give them lectures. And as soon as I said that, it's like, well, you don't get to do any more lectures. Mm-hmm. And this is what happens whenever the doctor-patient relationship has somebody else in control of it. Right. Whether they have control over it by law, by saying, look, these are the things you have to do to keep your licensure or your board certification or whatever thing, or whether they do it just by financial controls. When they interfere in the doctor-patient relationship, this is the kind of thing that happens because that third and fourth party doesn't feel your pain. Oh. They all say they do, but it's physiologically untrue. They don't feel what you feel.
It's they're tying the hands behind your back and not allowing you to do what you know best.
And in fact, this is why the second party, because the second party in this relationship is the doctor, must not be the man in charge.
Right.
The money has to be coming from the patient to the doctor so that the second party works for the first party and not vice versa.
Yeah.
It doesn't work. The doctor can't be the boss. He doesn't feel what you feel either.
Yeah.
He's just supposed to say, okay, if you feel that and you have this, this, and this, then you'll probably feel this way if we do that and this way if we do that. Yeah. But he still doesn't feel what you feel. So your doctor can't be your boss either.
I love that. And you can't, on your website, again, you tell people, like, I'm the patient, I'm the boss, and you are my servant. And that's impossible in the third party system,
Oh,
third-party
absolutely.
payment system is what I'm hearing you say.
Right, because as soon as you give your money to that third party, either via a premium or your taxes in the case of Medicare and Medicaid, as soon as your money is given away to the third party, you no longer become the person who is paying the doctor and controlling the doctor. As a matter of fact, I tell anybody, when you go into that doctor's office taking your insurance and you sign up to be that doctor, did you sign a contract with that doctor? You didn't. That doctor has no contract with you, but he does have a contract with the insurance company and the government.
So the way it is kind of set up in the third-party pay system is that both you and your patient are servants to the insurance company or government.
That is entirely correct. Or the employer in the case of an employer.
Or employer. And that's just so topsy-turvy.
Right.
So I wanted to also segue a little bit into, I love on your website, PureHealth Functional Family Medicine. Can you explain to us what pure health means to you and what functional means to you and what family means to you and what the opposite of that might be?
Sure. Well, I think the pure health surprises people because they know I do functional medicine. They think, oh, he's a guy who never uses drugs. I tell somebody, well, no, it's not where the pure health comes from. The pure is there because nobody has any ability to influence my opinion except the guy on my exam table.
Good.
That's why it's pure. No drug company, no supplement company, no lab company, no employer. That's why it's pure. The advice is just biochemistry, anatomy, physics being put out to you without any financial influences to disrupt what that thought would be. Then the functional part, I have a colleague who I like to say, well, functional medicine is another word for medicine. And when we got into our degrees, what the idea was, we're going to take a person who says, I don't feel the way I want to feel, and we're going to make you get back to feeling the way you want to feel. Well, that's not really what healthcare has become. It's become a disease maintenance system where we maintain your disease. We don't really care why you feel the way you feel and how you ended up feeling this way. And we're not really trying to figure out a way to get you back to being normal. We're just trying to figure out a way to make whatever the third party says is good health care occur. So functional medicine says, no, we're going to think it deeper than this. Putting a name on your demon, whether it's bipolar depression or high blood pressure or diabetes, that isn't the end of the work. The end of the work is when I can say, I know biochemically all of the steps that got together to make you, so that process that got you this label on you can be figured out how you got here and how to get back from there. It's basically get down to the biochemical level of how did you end up not feeling the way you want to feel? How would you feel if I made you feel this other way? Would you think that's better? Okay, here's how we get there. And then the family medicine, that comes from what my own personal view of what family medicine is and because of what it used to be. 25, 30 years ago, what it was your family doctor was the master of every common problem. He wasn't, I don't suck at stuff, I'm just not really good at stuff. He was the master of common stuff. Uncommon stuff, he could take a shot at and make sure he didn't hurt you taking a shot at it. And then the rare stuff, he had a specialist he got you to take care of that. Well, what family medicine has become is I don't really know anything. I just know how to get you to a guy who knows something. And that's never what I wanted to do. I wanted to be hey, look, from cradle to grave, if you have a problem and it's common, then I want to be able to go toe to toe with any specialist who does nothing but that work and discuss it.
And I will attest, you could do that. You have this computer brain, I say, not an encyclopedia brain, a computer brain. It's amazing, Dan. Go ahead.
I'm pretty geeky. Yeah,
you're so smart. Brilliant. Go ahead.
I remember somebody coming up and saying sometime that, I was found to have a selenium deficiency. And I said, oh, that's very interesting. Now let's figure out why you got a selenium deficiency. And they said, what? I said, well, we got to know, is the problem that you just don't take enough selenium in, or is there something driving the selenium out of you? Because, otherwise, if it's you don't take enough in, then we're going to, give you one dose of selenium. If it's something driving the selenium out of you, we need to find out whatever that is. And if we can stop that. And if not, then we're going to have to give you a bigger dose of selenium the rest of your life. And we really want to go one step deeper into this till we get down to the chemistry of how were you when you were healthy versus how you are now. What are the biochemical and anatomic physical differences between those two states so that we can move this back to that?
But that's
And
common sense, and a lot of geeky guys don't have common sense. So it's so brilliant. I mean, it's we just don't think common sense wise in medicine a lot. So your brilliance is taking you back to the core of, what is the cause,
yeah,
and
it's
that's common
amazing.
sense.
In medical school, we were kind of taught that logic was different for doctors than it was for everybody else in the world. Kind of a very uncomfortable position to be in. But, when I would ask questions in medical school and they would say no one knows the answer, I would say things like, oh, you've spoken with everybody in the world? That didn't make me real popular with some of my teachers, but
That is so funny, Dan. So let's go into what's hot off the press. You always know everything, like I just said. So anything
so
hot off the press?
yeah, a change in the actual insurance marketplace. So first of all, people need to know how the insurance marketplace works right now in the era after the Affordable Care Act was passed. So as part of the Affordable Care Act that was passed, insurance companies were now required that they had to spend 80% of the premiums they took in on medical expenses, and only 20% could go to paying their stockholders, paying their employees, and doing administration. So that sounds great when you just, oh, God, see, those guys aren't going to be able to just pocket all that money. Well, unfortunately, what it converts an insurance company into is a prepayment scheme. Because if they want to pay more to their employees and the shareholders, the only way they can do that is they have to spend more and more money on health care. And then the percentage they get 20% of goes up. So they came up with these coercive networks, our network of doctors. They've agreed to our rates. And these rates, they're good rates. Well, actually, they quit trying to get the rates down because the higher the rates were, the more they could raise your premium and the more money they would make. So the only check on this system now was whether or not the employer would scream enough or the government would go bankrupt fast enough. Because the way they were getting people in this prepayment scheme, which is what it became, was to say, well, okay, look, the problem is more and more people were dropping out of insurance before the Affordable Care Act because the third-party system just inflates prices. And everybody was dropping out of the system, so they said, we've got to mandate that they go into the system. And so the two ways they mandated that was, one, if you're an individual and you don't buy insurance and your employer doesn't offer it to you, then we're going to tax you. And the second was, if you're an employer who hires 50 or more people, you must offer your people insurance and give it to them. And if you don't, we're going to tax you. So basically, they used your employer as a way to funnel you into the prepayment scheme, where you could be sheep sheared out of all of your money to keep this system working. Because the privately insured people, another facet of this most people don't know, hospitals and doctors lose money on every Medicare and Medicaid patient they see. The government doesn't pay its bills. They don't pay market rate for any of the services they have. And so the only way hospitals and doctors stay in business is to financially pilk everybody who doesn't have Medicare and Medicaid. Eventually that makes people get out of the system. And so we had to force them back in the system. And so the Affordable Care Act came around. Well, unfortunately, the inflation has become so great that many employers and even some people who are sick of the insurance system said, hey, there's a loophole in the law in that, right now the law says that you're not allowed to offer your employees an insurance policy with a deductible greater than $6,550. But somebody found a loophole that said, hey, you could have a medical spending account set up for the corporation that had sub-accounts dedicated to the employee, and you could have a great big deductible for the employer, and then you could actually have a way to get around the language and offer your patients a very high deductible health insurance program with a nominal cap at $6,550, make a very high, big medical spending account, get this very high deductible policy for a very small premium. Put the balance that you didn't spend on the other premium into their medical spending account. And what made this work is this new insurance company, one of them that's big on this is Allied National, has no network and agrees that everything you buy on an open market will apply can be taken out of that medical spending account and will apply to your deductible. So right now, if you get Anthem, so if you get Anthem right now, I'll give you the best example. A guy comes into my office and says, Dr. Stock, I have Anthem insurance. I say, okay, well, I think you need a complete blood cell count, and here's the reasons why. And the patient says, I agree with your logic, Dr. Stock. Let's order a complete blood cell count. So if you walk into the local laboratory and you say, I want to use my Anthem card to buy my complete blood cell count, then they will say, okay, that'll be $25. If you have a deductible for your labs, you'll have to pay $25, and that will count towards your deductible, which let's say it's $2,000 a year. Well, let's say you said, wow, okay, what if I just pay this cash? The laboratory will say, oh, well, then we're allowed to give you a 20% discount. It'll be only $20 for the complete blood cell count, and it won't count towards your deductible. Mm-hmm. All right. But if you buy that lab through me, because this is the open market price, that very same lab done on the same machine by the same technician in the very same room will be about $3.50. Oh, but again, it won't count towards your deductible. Right. Which means unless you buy it through the insurance company, all of that $2,000 deductible is still hanging over your head to pay. Yeah. So what this policy allows employers to do is to say, I'm not going to go get from Anthem and Cigna and Aetna and all these guys who run prepayment schemes. I found a way that I can get a policy that allows my people to apply anything towards their deductible that comes out of that medical spending account. And now you can rent your doctor through direct primary care without a financial penalty. Right now, if you have Anthem insurance, you can have Anthem insurance, but any of the money you spend to get unbiased advice from me, that doesn't count towards your deductible. We're not calling for it in most cases. Now, all of a sudden, the patient says, no, I can go get market rate advice that's unbiased. I can go get market rate services on labs, medicines, supplements. Drugs and supplements now are in the same market. If you have insurance, they don't have to pay for your supplements. They aren't part of the prepayment scheme. Right. So financially, if you use your money on a supplement, that doesn't come with your deductible. You just gave that up. Now, all of a sudden, the patient is empowered because he has a networkless insurance company. His employer gets out of the relationship. All he has to do is say, look, here's your medical spending account. All right. You go do what you want to do. Almost always, this is cheaper for them to go get a direct primary care doctor because we order a lot less stuff for you and get the same outcome. Oh. And everything applies to your deductible. And now insurance is back to being insurance. It's not a prepayment scheme anymore.
Oh, my gosh.
So more and more employers are realizing that, well, this does a bunch of things. First of all, it gets the employer out of the third-party payment status. It frees his patients from needing the insurance company third-party status. It lets everything drop down to market rate, not the inflated prepayment scheme rate. And it allows him to pass the money through without getting taxed by the government directly to his patient.
Nice.
Yeah. So another thing that's true in our healthcare system nowadays is if you as a patient go out and buy an insurance policy for yourself, you don't get a tax break on that. If your employer buys it for you, he gets a tax break. Oh. Yeah, he can write that off as a business expense. You can't write that off as an individual. And so it kind of makes it so that everybody needs their employer to have ability to get to the market if they want to buy insurance. Well, now, frankly, you can go out and buy insurance now and be able to get this at a rate which doesn't behold you to get into the prepayment scheme. The other new thing that's come out there, there have for some time been what are called medical cost sharing arrangements. These aren't insurance. They don't agree they're going to pay for everything. But they are a group of patients who just get together and said, hey, we're going to agree that if anything happens like this, or this, and this, we're going to pool money, and we're going to use our money to pay for that. Before this, they were all run by ministries. So you had to be a member of this church or something like that to be part of this system. But now there is a company called Sedera Health, which is actually just being the manager for a medical cost-sharing agreement the patients can do as well. They actually require that you have a direct primary care doctor because they know that the expenses of going through the prepayment scheme will make you always in their cost sharing. And they know that they can't take people who are getting that kind of advice into this because it just makes the things get expensive. But then for that, we're talking rates that are usually in the neighborhood of a third to a quarter or less of the premium for an insurance company, and will still cover the big ticket unforeseen expenses. That's kind of a thing we don't really do anymore because, insurance is never there to take care of the stuff you know is going to happen. I mean, if you have high blood pressure, you know you need to spend some money to make some changes or you're going to stay with high blood pressure. But that's not what insurance is anymore. It's a prepayment scheme for all the stuff we know is there. It's not just there to take care of the stuff we can't see coming. These high deductible medical spending account plans that employers can opt into, or these like Sedera Health, these cost sharing arrangements, actually get insurance back to being what insurance is, where we're only taking care of the stuff we can't foresee coming, and everything else is bought on an open market. But what you buy on the open market doesn't penalize you because you didn't buy it through the prepayment scheme anymore. So it levels the direct care. It levels the playing field for direct care and opens the market back up to patients again.
So this MSA schematic you mentioned for the employers 50 or over employees and the cost sharing program, in your second example, you mentioned they might be loopholes or at least discoveries within the current system that allows this to happen. Any chance that the legislature or the Congress is going to close those loopholes?
I don't think so. I think the gridlock in Congress right now is so terrible because it's not just as simple as they don't get along with each other anymore.
It's not just as simple as honestly, the government's closed right now, shut down.
No, it's not as simple as that. It's the truth is, the people in Congress have been paid to maintain this prepayment scheme. It is very profitable to the people in the insurance industry.
Yes.
And it is keeping the sham of Medicare and Medicaid afloat. Mm-hmm. Unfortunately, it's so inflationary, it's falling apart, it's got all kinds of problems, nobody likes it, and Congress really isn't sure how to keep it going anymore. It's clearly failing. There's actually been a move in Congress to try and make it so that the Medicare and Medicaid programs can reimburse doctors for doing direct primary care.
Oh, nice.
This is a little bit nerve-wracking because they actually tried this in Washington State with Medicaid, but the federal government said, okay, you can do a direct primary care membership arrangement for the Medicaid people, but the doctors still have to do everything we tell us to, including report all their data and use an EMR that we like and all these things. So
in other words, you're still a slave.
Right, yeah. So
an indentured servant, as you say.
Yeah, it's only going to be useful if Medicare says, hey, look, you can choose one of two things. You can choose to have a primary care doctor or a doctor through the traditional system, or you can choose to do direct primary care. And we'll reimburse for that. But if you do that, then you don't get to go get any other family doctor you want. You only get to do direct primary care doctors. That's the only way it'll be useful. And frankly, because it would so undermine the insurance company guys who are lobbying Congress so hard, I think the only way that's going to come about is if the people in Congress just realize it's going to explode and die, mm-hmm. and we're going to be responsible, and the only way out of this is to approve it. So although there is already relief in sight for the Medicare patients, they actually have an opt-out on this they don't know about because they've not been told about this. But there's a way for a Medicare patient to actually get out of that system already.
Good. Let's go into that because I was actually going to want to segue into the Medicare system. And we can talk a little bit about how you alluded to a second ago that the third-party pay system is actually in place to fund Medicare and Medicaid, is what I understand. Yeah. And so if it does implode, if the third-party pay system implodes, then Medicare and Medicaid are going to have to be funded some other way. And maybe that's another story, another interview. But let's get into... Yeah, go ahead.
I was going to say... that won't get funded. There's no way to do it. It's too financially inefficient. What it will be is we're going to let the little old people and the poor people sit out on the street till they start to smell bad. Then we'll sweep them up.
Isn't that already happening?
Yes, it is. It's being hidden from them that it's happening, but they're already deciding that, no, this particular treatment, we're not paying for that. You'll just die. It's already happening already.
So, okay, I'm not going to reveal I will reveal my age. I'm 62, so doggone it. I hope I don't look it yet, but I'm doing everything I can, doctor, to keep my body and mind and spirit young. Do everything you advise. However, that 65 is coming up, rolling out in 3 years. Help! What do I do? Because
So,
I'll be honest. I'll be honest with the viewers here. I think I've mentioned this before. For 2 years now, I've gone bare. I mean, I have some savings, so I'm doing my own self-insurance. Now I'm having to pay the fine, unfortunately, which I think I have to pay again because I don't think that goes away until after next tax season.
starting for the 2019, you won't get a penalty in 2020 if you don't buy insurance in 2019.
Right.
So you don't have to buy it. You don't have to buy into it this year.
So, but I get a penalty because I didn't buy into it last year and the year
Correct.
before. So, doggone it. I was thinking I was free this year. Anyway, so I've gone bare. So far, so good. Cross my fingers. Now I'm going to be, but in 3 years, you advised me off camera. I need to go on ahead and sign up for Medicare because I've paid for it through all my taxes and, being a very good lawyer all these years. So I should opt into it. Tell me what to do. Help.
Well, see, this is where the keeping people confused about the system is in the government's advantage. So most people know there's parts of Medicare, but they don't know what these parts do. Mm-hmm. So Part A, that's the part that pays for devices and drugs and hospital stays. It doesn't pay for services, but it pays for goods. Part A is actually something you get at the age of 65, and it costs you no extra money to get it. Mm-hmm. You're entitled to it just because you've been a taxpayer. Or for that matter, you don't even have to be a citizen. If you put any money in the system, you're entitled to Part A. So that covers all your labs, x-rays, hospital bills if you're in the hospital system. It does not pay for the services of individuals like doctors and physical therapists. Mm. So then there is Medicare Part B, which does pay for those services. And you can buy into Medicare Part B, but Medicare Part B will cost you about $130 a month. So you're not obligated to Part B. All right, you have to pay extra for it. It is how the third-party payment works to keep your doctor in line, keeping the Medicare budget close to where it's at. But you have the option to say, no, I'm going to take Medicare Part A, and I'm going to decline Medicare Part B. And that's $130 approximate dollars every month that you have in your wallet.
That I can go on your kind of subscription plan.
Right.
Okay.
And I tell people if you sign up with my service, if you do a yearly contract, you're going to be paying around $75 a month. Oh. Now, if you do the math on that, that means you got $55 a month.
I could take people out to a nice dinner.
Or put it in a savings account and save it to spend it in the healthcare the way you want. And so that's what I advise people to do, because now you'll get Medicare advice, which is not coerced. The doctor doesn't have the financial gun to his head that says, hey, do this. The other thing you need to know is if you say, well, I want to go find a doctor who's not employed by a hospital, good luck finding one who takes Medicare. It's financially impossible to make that practice work because they don't pay individual physicians with insurance companies pay individual physicians very poorly. The only way
you
to make
don't
it work
take Medicare because it's not financially feasible anyway.
Right. Well, for two reasons. First of all, it's not financially feasible. And second of all, I'd have to do what they told me to if I wanted to keep it. If I wanted to, get my very low salary that would make me not be able to make my house payment, I would have to do what they told me to.
Right.
So I tell people, once you sign up with Part B, you've just invested $130 a month in a prepayment scheme for healthcare advice that's not only highly coerced, but very sparsely available unless you go to somebody who's employed by a hospital or a healthcare center or somebody who's under federal largesse to pull this off.
Okay, so wait a minute, back up. You mean I would have trouble finding a physician under Part B unless I went to those facilities, hospital, et cetera. So I couldn't just pick my guy or gal.
So there are a few independent doctors who take insurance still. Mm-hmm. More than half the doctors in the country now work for a healthcare system. Okay. Or they work for a federally qualified healthcare center, which is kind of like a hospital for poor people, if you would. They still got to do everything they're told by the federal government. Very few doctors are in private practice anymore, and the ones who are don't take Medicare and Medicaid at all. Okay. So let's say you said, well, I want a person that I don't want them under the government's thumb. Well, good luck finding that when you sign up for Part B, because those guys aren't taking Part B because they make them go bankrupt. But if instead you say, look, I get Part A without any extra cash out of my money because I paid taxes. I'm entitled to it by my taxes, but I'm not giving you $130 a month. I'll go find my own doctor and pay him my own way. Then you get out of that, and you can now get your advice in an unbiased fashion. So I tell people they tend to package this when, oh, it's time to sign up for Medicare. You want Part A, and for Part B, you get that, and it's only X dollars a month. And then you get all your doctor bills paid for. And they set you, well, let's get you signed up for that and have you ready to go. But you can say, no. I've heard there's another way to do this. I just want the Part A, and I don't want the Part B. I'm not giving you any money for the Part B. I'll just keep that in my bank account and pay for it and rent the doctor I want the way I want him rented.
Wow. What about the scared person that thinks, oh my gosh, I'm going to be spending a lot more than $130 on doctor's bills per month?
Well, you probably, I can tell you that as far as those of us who do direct primary care, we do about 50% of the referrals of the people who are in Medicare Part B acceptance. That's because the hospital systems basically tell these doctors, look, we lose a lot less money on Medicare when we operate on you or when we do something expensive through a specialist than when we do through a primary care doctor. So your job now is to refer them to our specialist. A good example of that is skin biopsies. So I do my own skin biopsies. I do my skin biopsies the exact same way that a dermatologist does his skin biopsies. Medicare will pay me a pittance for my skin biopsies. It doesn't pay full market price for a dermatologist to do a biopsy, but it pays a lot more for the dermatologist, a lot more for the general surgeon to do this. So a hospital employs dermatologist, general surgeon, whatever it is, and says, family doctor, I know they came in and they gave you that co-payment because they got that $130 a month thing going. You don't get to do their skin biopsy. We're tracking how many referrals you did. If you don't do enough referrals, we're going to give you your walk-in papers. You need to send that to our surgeon or a dermatologist. So a lot of the extra money that you spend goes, oh, I'm going to need to see all these extra doctors. Well, a lot of that's because you're made to, because the guy you had to see first is required to send you out there or they'll bankrupt him. But the guy that I wanted to go to in the hospital setting refers me to someone else that doesn't take Medicare. Is that what you're saying? Or they do? No, that specialist is now hospital employed as well.
Okay, so I'll still get the service under. Okay, right. I just want to make sure I understood that.
Right, you'll just pay a lot more for it.
Yeah, I'll just pay a lot more.
You're still going to get your skin biopsy, all right?
But how much do I pay? Is the copay a lot more? Is that what you're saying?
Oh yeah, you're going to have to pay not only for the primary care doctor, so you're going to go in him, and let's say you got a $30 copayment to see the primary care doctor. So you got your $130 a month.
Yeah.
Your $30 copay to see the primary care doctor, who is going to refer you to the dermatologist.
Yeah.
Now you're going to have a $50 copay with the dermatologist. All right.
Gotcha.
Now remember, there's a deductible with Part B too. All right. So you have to spend a certain amount up to this. Yeah, that's right. So that's all counting towards your deductible. But now you just spent $30 plus your $130 plus $50 for the specialist, and all that's going to your deductible. You just added what you spent in a month. Or if you'd gone to a direct primary care doctor who says, I'll just do the biopsy.
Yeah.
Or half the time I'll tell them, look, I don't need to do that biopsy right now.
Right.
That biopsy is going to send off to the lab. It's probably going to be covered for you. But, the other option we could do is we could just watch this and see if this thing doesn't change. Because if it doesn't change, we don't have to do a biopsy. That's the advice you get when the guy doesn't have any financial coercions on him.
But the little old lady like I am, I'm going to be just hopping around all these physicians, having all this work done and all this copay pile up. And by the end of the day, I've spent $300 that month on not only the $130, but all the copay, going to needless situations. I mean, I don't even need it, maybe.
As a matter of fact, I have a Medicare patient in my practice who developed a problem with dizziness and went to his primary care doctor, used his Part B, spent a lot of money, got sent to cardiologists. They ran up $25,000 in testing, none of which found anything. And then he ran into me and I said, oh, really? Yeah, well, let me hear your story. And, oh, I see what it is. You're having migraines. Don't need to do a test to say that. Your story is pretty classic for vertiginous migraine. What we need to do is start treating this, and, did some labs which got covered by his Medicare Part A, started him on a medicine that His cash price is $20 a month, and the migraines go away and the dizziness stops.
Gosh, that's amazing. Now that 25,000 that they had done previously, was that all lab work, or was that, what I'm trying to get at is, okay, was that all lab work, that 25,000 in tests?
No, I'd say about 20,000 of it was getting treadmills and laboratories and things done. But you have to remember, when you go to a cardiologist who does a treadmill for you, the bill for that treadmill, let's say it's a regular old treadmill, not even a special one. Good luck getting anybody to advise just the regular old treadmill. But that treadmill, it may be that there's a $200 charge to be on the treadmill and take all the recordings, but then the guy who recommended it to you, he'll make about $400 reading all of the data that's collected. Well, that's doctor services. That's not covered under Medicare Part A. The $200, that's covered under Part A. But the $400 for the doctor to read the test, well, that's not covered under Part A. That has to be paid for out of Part B, and you have a deductible, and so there you go. And there's a copayment with it, and so this all starts adding up again. This is, again, a conflict of interest when the specialist who recommends the test is going to make money on the test he recommends. Yeah, I know that's a little bit conflict of interest there, but very quickly, because the system of third-party payment doesn't let the patient define what good health care is, and the guy giving the advice has financial coercions as to what advice he's going to give, it ends up becoming very, very expensive because he is going to give expensive advice because it's budgeted.
So if someone's a really sick patient, are there any circumstances that you would recommend people opt into the Part B as well?
Maybe short term.
Okay.
Let's say you come into me and, Doc, I've got stage 4 heart failure.
Okay.
Well, stage 4 heart failure, you may get a lot of hospitalizations done. And I'm not your guy when you're in the hospital. I don't have privileges at hospitals. I'm not well studied in hospital care. I don't have any stage 4 heart failure patients in my practice. I know how to get them back from stage 4, get them well. All right. But in this interval of year, while I'm actually curing you, you may need some guys to prop you up from time to time. And that cost, you go into the hospital, that hospitalist, his bill isn't covered under Medicare Part A. It's under Part B. You might be financially better off for a year to have that. Now, that's assuming you have a severe illness that I can't take care of. You might benefit for a year or two of being in Part B. That probably is the vast minority of people who have Medicare.
Okay.
The vast majority of people who have Medicare are going to be off just from the get-go saying, look, I maybe got blood pressure and cholesterol problems. I'm not going to need specialty care advice to get me through the next year. Screw that. I'm just going to put my money in the bank account and not get Part B.
What if I'm 66 under Part A and I have some kind of a surgery I need in the hospital? The surgeon's bills, the services under the physician's surgeon bill, I have to pay for, right?
You do, but I can tell you there's a development on that front as well. We are actually finally getting specialists who have decided I'm just going to be a cash pay specialist.
Oh, interesting.
So, for instance, we now have an orthopod here in Indianapolis who does nothing but cash pay. We have a gastroenterologist who does things cash pay. So if you need something, I had a patient who needed a colonoscopy done. It's like, well, you don't have any insurance, right? Well, dude, I know who you're going to see because, I can get that whole colonoscopy done, everything included for $1,000. You walk into a hospital and have that done, baby, you're not getting that less than $2,500.
Oh my. Okay.
By the time you pay the doctor and everything, but this $1,000, you get the facility fee, the colonoscopy, the doctor's service, everything paid for this. We're actually seeing specialists now who are doing that, including some cash pay surgeons who will, hey, look, the hospital is going to get paid by Part A. You got that covered. I'll come in and take care of your surgery and all of that, and we'll do that under Part B. And
one last scenario here, so the patients and me understand, the viewers understand. Let's say I have a friend who is turning 65, and they want to know whether to do Part B, and they know they have cancer. So, I mean, that's already determined. Or maybe let's go a different route. Let's say that midway next year they opt into Part B. No, they don't do Part B. by July they find out they have cancer, but they don't have Part B, and they can't sign up for Part B until January of 2020, right?
Right, correct.
So what happens? They go into the hospital, and maybe they're going to potentially incur a lot of doctor's charges, right?
That's true. Although you can find oncologists who are taking cash on the outside market. Remember, and those oncologists go to the hospitals. They all have privileges there. And so, you're not necessarily, remember the hospital bill, the chemotherapy, the agent sales, that's all going to be covered under Part A.
Right.
All right. Or Part D. Part D is the medical prepayment scheme for medicines for Medicare. But those are going to be covered by those things. So the doctor services, you could get some expenses out of that. I think on average, the Medicare patient is going to save money if he gambles on not signing up for Part B and finds a direct primary care doctor.
Right. And then the Part D, as you said, would pay for the chemo if they were in that
Part
situation.
A.
Part A would pay. Okay, what would they get under Part D? You were saying the cancer patient
is drugs the federal government has decided it will help you with. It runs a prepayment scheme for drugs.
I thought that would be chemo too.
Well, see, this is the problem. The federal government gets to decide what's going to be in Part A and what's going to be in Part D.
Oh, Lord.
The decision-making process is usually a budgetary one. It's got nothing to do with biochemistry and science. Many medicines are actually covered under Part A. Some vaccines are covered under Part A, although interestingly, some are not. Most chemotherapy, and don't quote me on this, but I think most chemotherapy is covered under Part A.
Okay, so that's the 130 would get you all those mainstream drugs, let's say. Then Part B, you're going to have to pay 130 to get some of these physicians within the hospital setting and those other places. And then Part D, we'll go to Part C in a minute. Part D are added on drugs that they deem is an additional charge. What is that for Part D?
That would be drugs. Yeah, that'd be like your blood pressure drugs, your cholesterol drugs, diabetes drugs.
Okay. How much does that cost per month? Do we know?
Nowadays that there are cash pay alternatives for most of this, and that we can cure people for most stuff who need them. I don't know what a Medicare Part D costs because they have several different plans available. I can tell you unless you plan on being sick for the remainder of your life and needing one of these expensive drugs forever, there are usually cheaper ways to skin that cat than buying Medicare Part D. You should recognize that Medicare Part D is just a prepayment scheme for drugs.
Prepayment scheme for drugs. Okay. So what's C?
That's really what it is.
Okay. What's C?
So Medicare Part C, Medicare Part C was the brainchild that said, well, governments administer these plans really badly. We're going to, instead of having the government administer it, we're going to let companies offer Medicare Part C, which is where you get Medicare Part A, B, and D, all managed by a private company like Anthem. Now, Anthem has to manage this, giving you all the benefits and following all of the rules that Medicare sets. So it's kind of this fantasy idea that the private manager of your third party is more efficient than the public manager third party. A really other way to put it is it's more profitable for Anthem than it is to just manage Part A, B, and D, is if they get you to sign up for Medicare Part C. And then the government will basically pay Anthem a premium to give you everything that it wants in Medicare Part A, B, and D. To tell somebody that it's a cost savings is, well, you have to pay a little extra in that Part C plan to get all of this. To say that it's made a big cost saving is probably not accurate, but the most important thing is it doesn't get you out of the coerced advice.
Right.
Because that Medicare Part C company is going to go hire a doctor and say, Medicare says you have to give this advice. So,
and it's going to keep you in the inflated price range.
Right.
Yeah.
And if you're a Medicare Part C doctor and you start telling people to go out of network and buy services, it becomes, hey, doc, we got to talk about this.
Yeah. Hey, doc, what do you want to prescribe for your little cough there?
Right. Yeah.
Get that going.
We don't see nearly a high enough percentage of your cholesterol patients and diabetes patients taking statin drugs, doctor. You're not a high quality doctor. We will have to pay you less.
Oh, Lord. Yeah, that's what I was getting at earlier, where the doctors seem to be penalized if they don't write enough prescriptions.
Yeah, the idea was to get the doctor outside of the regulations, but
Yeah.
the way the Part C is written is it's just a private person paying to enforce all the regulations instead of the government paying to enforce all the regulations. So to indicate that Part C is somehow different than Parts A, B, and D is kind of like in that being hit with a sledgehammer is different than being hit with two ball peen hammers. It is different, but it's
I
a
love
difference
this.
that really
And
makes no difference.
you have been an invaluable resource for all of us that are going to be embarking onto this Medicare prepayment system. And I for one, am so thankful to have an informed decision now coming up on that, and to be able to spread the word and to share this video far and wide with everyone. So many things that you've revealed in this conversation, this interview, and it's so important for us to begin the journey of understanding how this all works from a panoramic view, so that we can, at the end of the day, take care of ourselves the best way we can. I love that. Are there Go ahead.
I was going to say, this whole system is built on the idea that you're so scared to take any influence or any control of your own health care. It can be, there, nice little patient. You just give us the money, and the government and the insurance company is going to take good care of you. It's based upon that. When you start understanding the system and you start asking questions, you realize that cell job is what's making this go, plus the fact that by law you have to put your money into the system or we go get you. That's why I think it's very important, and I would encourage any person who gets their insurance right now through your employer, go to your employer and tell them, hey, we would like you to look into switching to a program like Allied National, where you actually spend the money this way and put the balance in my medical spending account, and let me have freedom to go out in the market and make this work. I can tell you that Freedom Health Works, which is a marketing arm that many of us direct primary care doctors use here, they will happily go talk with any employer who expresses an interest. And we doctors will even show up there beside them and tell them, hey, this is what you're going to get if you get a direct primary care doctor. So, for instance, I tell people, well, Dr. Stock, what do I do if I have a problem that develops after the office closes? Am I going to, do I just wait for the next day? Or, I used to see this doctor through the hospital, and, I had this nurse practitioner or this nurse triage that talked to me first, and then they would put me off to a nurse practitioner triage person, and I never really ever got to my doctor. It's like, no, in direct primary care, you have a way to get through to my cell phone.
I love that. Just
so if you really have
bypass it all, right? Direct.
Unless I'm on vacation, if it's Dr. Stock, I think I have a problem that won't wait till the office reopens. It's like, okay, well, you're not going to talk about that right now then. And,
oh, that's so good. I love it.
The other thing people don't know about this system, they need to know about, this third-party system pays doctors better if they will see 10 people for 6 minutes than one patient for an hour. Now, this is huge, because remember, this doctor came out of medical school $250,000 in debt, all right? And if he's not making enough money for the hospital, because like I say, they lose money on all the inpatient stuff, Medicare and Medicaid, they lose money on. They actually pay doctors they take money that's being generated from outpatient care and use it to pay inpatient bills. So, doc, we really need you seeing 25 people a day. But you go to a direct primary care doctor, I got to tell you, a whopping busy day for me is I'm going to have 8 people in the office and do 2 or 3 phone consultations.
I love it.
And my new patient appointment's 2.5 hours long.
So nice. I'm glad you mentioned that, because we did talk about some of that in the last interview. And I encourage all of you out there to look at the interview that we did last year, I think in February, around this time in February. And you'll get a lot more information in that video as well. Are there any other things?
A lot of people.
Go ahead.
I mean, I feel bad because a lot of people say, you know what? I don't think my doctor really cares. I walk in the office, he never looks at me. He's on that computer all day long, and he's 7 minutes, and he's, okay, do this, and he's out the door. And they're like, I don't think he really cares for me. I say, I don't think you understand. If he has stuff he has to enter in that computer for the government and the insurance company, and if he doesn't get it in there, he doesn't get paid. And he gets, if he doesn't see a certain number of people per day, they're going to cancel his contract. So, look, he might really care about you, but the system doesn't. And the system has him by the short hairs. So, yeah, you're getting 3 or 5 minutes with your doctor here today, and maybe you're going to see a parade of physician's assistants in the meantime who aren't going to be trained to answer all those questions. You're never going to get to see your doctor, but those, 5-minute things. It's not that he doesn't care. It's that, guys, he's got other things to care about.
Right.
Direct primary care is like, I don't got any of that. I don't, if I want to send you an email, you don't have to go through some secret secure server thing where you have to remember 5 passwords. And I just send you an email. You want to send me an email? You send me an email. You want to send me a text? You send me a text. I send you a text. Like I say, when after a call, you don't go to this big rigmarole where you triage through. You think you need to speak with me after hours. You hit the button. If I agree we need to take care of this today, I'm the guy who's going to make the decision talking with you, hearing your story. So it gets everybody out of the doctor-patient relationship except the doctor and the patient.
I love that. And it takes the influence of money out of the system. Right. And then encourages you to be the servant. And it's not just parity between you and the patient. It's actually you're the servant to the patient. I love that. You're empowering the patient to take charge of their own well-being. And you're the facilitator. And I think
it also it does this really interesting thing in that the only way the doctor can make any money in direct primary care is by thinking about what you might think was good. Mm-hmm. And I'm in competition with every other doctor. Right. And so if there's something that might make you better and I don't tell you about it, and then you find out this other doctor did know about it, are you going to stay with me? No. So like, my nose is not only not in my hiney, it's in a book. All right. Yeah. I got to be smarter than the other direct primary care doctor here. That's my motivation to keep doing this. So a great example I use for people, you go in and say, well, doctor, I got blood pressure. Okay, here's the medicine you take. These are the labs that you need to do. Really? What if I told you there's a study that shows 60% of people with a dietary change in supplements will have their blood pressure go completely back to normal again. And by doing so, will have less heart attacks and strokes than if they take blood pressure medicine.
I love it.
Long conversation to teach you how to do all that. But you know what? In my practice, if I don't tell you, you know what? You got high blood pressure. 60% of the time, we just do this, 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 and the other and take these supplements. You're going to be off all your blood pressure medicine and having less heart attacks and strokes than if you stay on your blood pressure medicine. I have a motivation to tell you that because I don't make any more money if I see 10 people for 6 minutes than one patient for an hour. If you're the guy who's been employed third party, you don't have time to say that, and it just costs you money to have that conversation.
Plus, you're dictated to by all the rules and regulations and template by the insurance company, so you don't even have any incentive to think outside the box as a third-party pay practitioner.
Oh, absolutely. I mean, if I told you that, look, blood pressure medicines take about 1.5 years before they show any difference in dummy pills, you might decide, well, instead I got high blood pressure. Instead of taking medicine today, I'm just going to go change my diet and all that. Well, here you are, the doctor. Look, I have to have a certain percentage of my blood pressure patients have to be on ACE inhibitor and ARB drug, and they got to have numbers that are this low. And if in a month and a half I don't have them down to that, they just start cutting my pay. You're going to tell them you can get out of this with diet. Now, here, let's talk for 1.5 hours about diet and supplements. Now,
I love that.
You're not doing that because it may take these diets and supplements 6-8 months to get your blood pressure down. And all the time, the third party guy is saying, well, you're dropping on the pay scale here, dude, and you know that's happening to you. So what advice do you give your patient? Do you go read that study about the 60%? No, you don't go read that study. I don't even get into how they're coercing what doctors can go study because they've actually financially coerced that now too. But I tell people there's a whole different thing when the only way a doctor can make money is to think about what you might think was good health care and to offer all these options. This is the result of, hey, he works directly for me, and the only way he makes money is thinking really good.
Well, I'll tell you what, Dr. Dan Stock, you are so brave and such a pioneer, and we are so appreciative that you've been on our show now twice to educate us about the third-party pay system, all of the new legislation and advantages to the loopholes that might be there, and then, also just navigating through the Medicare system. And where can people find you, Dan? Those that want to get into the direct pay system and start to get their health in line.
You can find me on my website at www.purehealthmed.com. My email address is drstock@purehealthmed.com. And our telephone number is 317-559-2515.
Awesome. And I'll have all that under this video as well. So any imparting comments before we sign off?
I would say to any employer who might see this, please go talk with the people at Freedom Health Works at www.freedomhealthworks.com, because we can actually show you how to get it so that you no longer have to funnel your people down the sheep shearing line of finances, so that we can keep the money both in your hands as the employer and your patient's hands. There'll be a lot more money for both of you in this, and you can finally get out of your patient's health care, which I'm sure you don't want to be in there, and I know your patients don't want you in there, and we can show you a way to get out of that.
And that's employers that have 50 or more employees.
Well, actually, any employer can use this to the advantage of their people.
Right.
It's a way that they may have to take some salary back, but many times it actually helps the employer. You look at the employees and say, look, I can either give you nothing and you can go out on your own, or if I gave you a little less, but we put it through this system here, you may end up with a system that allows you to get out and get this health care at a price you can afford.
Nice.
And so it can be a way for, even if you don't have 50 employees, especially if you're an employer who's self-funded. Right. If you're a self-funded employer, I'd tell people, you have no idea how the system is ripping you off.
Okay. I'm going to put that underneath the video as well for people, so so that they have that link. Anyone that's viewing this, if they're an employer and they want an option, they're self-funding or they're just not giving anything to their employees, they want another option. So awesome. Well, thank you so much. It's a beautiful day today here in Indiana. It's like a spring day in its 50s and sunny. So I know you're going to have to get back to work, but I think I may have to go out and enjoy the sunshine for a little bit here.
I recommend that greatly.
Would that be good for my health, Dr. Stock?
Well, it makes me feel better. So I haven't found any downsides to it. Use eye-power sunscreen, you'll probably be fine.
Okay. What about coconut oil? I don't like to put any of the gunky stuff on.
There's actually a sunscreen that's made by a company called Life Extension.
Oh, okay.
Their sunscreen components actually don't just destroy your skin terribly, and they actually aren't. They're designed to make sure they don't generate a lot of oxidative free radicals. Actually, many of the sunscreens have a sunscreen component in them that actually makes them generate cancer-causing chemicals in the sunlight. The one by Life Extension, they comes both in a spray and a cream. Doesn't do that. So it's a suntan lotion you can use that actually is helpful. Coconut oil actually doesn't protect you from ultraviolet light, but the Life Extension sunscreen will. So,
this is a perfect example of this walking computer brain that I'm talking about.
That
People
ain't my
out
job,
there,
ma'am.
you have got to go see Dr. Dan Stock, if not yesterday, tomorrow. So, and again, it's been such a pleasure, and I thank you so much for being with us today.
You're very welcome. It's been lots of fun for me.
Where we imagine, visualize, and create our dreams for society, a world with beautiful health care and well-being, and the money issues are gone. Yay! So with that, until next time, we wish you all well.
Take care.
Bye-bye.